general
Yeah,
examination?
yeah, sure. Hmm.
Child is conscious, moderately built and moderately nourished with no abnormal faces. Child is active with no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy and pedal edema. Child is febrile. Pulse rate is 90 beats per minute. BP is 90 by 60 mm of Hg. Respiratory rate is 14 beats per minute. Attained milestones according to the age, and the height is with height, weight, head circumference and mid-arm circumference are within normal limits, ma'am, to the corresponding age.
By milestones, what do you mean? What has she attained? What is she doing on her own?
At 9 months of age, she's standing with support, ma'am, with the pincer grasp present, and she's uttering bidecibel words, ma'am.
And her hearing and all are okay,
Yes,
as
ma'am.
you can see.
Yes.
Okay, actually, just going back to the history, there's something else to mention, that the child was well for 8 months, if we go by history only. So that means the fistula's opening is probably not narrow, because you're not had to dilate, you're not had to give enema or laxative. So
Yes.
the fistula's opening is reasonably a good size. Is better for, I mean, that's how they present a bit later also. And probably, I think pouch colon must be there in your place also. It kind of rules it out, because if you have a reasonably good opening but child has constipation, then you have to rule out pouch colon. Even much earlier in life they'll present. So these things are ruled out, isn't it, in some
Yes.
way by
Yes.
your presentation. Okay, but why are you using the word moderately built? What is in your mind? Do you feel she's a bit weak, or why are you saying that? The previous slide? Okay, doesn't matter.
Shall I start now?
Yes.
Examination of the abdomen. On inspection, abdomen is mildly distended. Umbilical is slightly displaced downwards and looking normal. There is no scars, sinuses, or visible pulsations or peristalsis, and all quadrants are moving equally with respiration. Hernial orifices are normal. On palpation, perabdomen is soft. There is no local rise of temperature or tenderness, no palpable masses. Renal angles are normal and hernial sites are normal.
Just wait. So from the palpation, so what masses you may feel, we've already discussed it in history, but
Yes.
or somewhere in antenatal ultrasound, what kind of masses you might get more commonly at a 9-month-old child with a vestibular fistula?
Any pelvic masses, ma'am? Like, and feculomas.
Yeah, that's more common. Of course, her diet seems to be more milk-based, I think. So that's a bit, it may not happen, but that's one thing which you should see, because it'll help you to decide whether you can do a single stage or need a colostomy. So, yeah. Because then usual other things for a kidney or
Associated lumbar masses, ma'am. Any hydronephrotic masses. Kidney mass.
Yeah. Bladder, kidney. Kidney may be ectopic also. You might palpate if there is some hydronephrosis and feculomas. These are the usual things which you will know. Presacral mass from abdomen you will not know. And they will present much earlier. And they may have an anal opening, maybe in a more normal location, but it will be stenosed. Longer length may be stenosed also.
On percussion, liver dullness is seen at the 5th intercostal space in mid-clavicular line. Liver span is 7 centimeters, and on auscultation, normal bowel sounds are heard.
So abdomen definitely, so in the general appearance, it is just like you should look at the color of the hair. Even hair I found when children have low protein, they're not eating properly, you'll have brown hair, and It's not a very good growth. So that also shows you some things. And was the child cooperative or crying all the time?
Cooperative only,
She
ma'am.
was okay. She was.
Sometimes yes, ma'am.
But there is a distension of the abdomen, from at
Yes,
least what I can see from here. There is a
yes.
distension. And the head itself is normal. Front. There seems to be some frontal bossing. Nothing much there.
No, ma'am. She's normal only.
Because see, you can have deficiencies of other things if the diet is not all right. So you should look for that also. Um, okay, next, because you haven't told me about the spine, but I assume you'll tell me later. What about the spine?
Last time mentioning, ma'am. Spine is normal, ma'am.
Okay, we'll discuss that later. So, okay, you're coming to perineum now.
Yes.
Okay. Just describe it, please.
There is an absent anal orifice with anal dimpling seen, with well-developed gluteal cleft and midline buttock groove, and well-developed buttocks, with well-developed labia majora and minora, with perineal excoriation is seen. The vestibule is showing three orifices. The upper one is the urethral orifice, middle is the vaginal orifice, and lower one is the vestibular fistula opening. On probing with 7-number feeding tube, separately, all orifices are patent, ma'am. On probing the fistula tract, the tube is passed posteriorly and upwards, and it didn't felt at the anal dimple, ma'am.
What is the interpretation of that? The
Possibility
last
of
finding.
differentiation between the rectovestibular and anovestibular fistula. It is a feature suggestive of rectovestibular fistula.
Okay, but don't you think? Yeah, I mean, theoretically it is correct, but presentation at 9 months is a little odd, I would think. But yeah, some people think rectovestibular is more common, so that is all right. So apart, when you passed a seven French tube, so that went easily, and you had some space around it also. It looks a
We have
little
some
small to
space.
me.
We have some space around it also.
Um, just tell me, what do you understand by the word vestibule?
The opening parts, it comprises of the opening parts of the urogenital and anal openings, ma'am.
Anus also. I'm talking of a normal vestibule.
No, ma'am. Normal vestibule, only urogenital openings.
What are its boundaries?
Above from the labia minora to the posterior faucet, ma'am.
Fine. Just go to the spinal examination.
All other systemic examinations are normal, including spine is also normal, ma'am.
Can you tell a little bit more about examination of the spine, especially the sacrum?
I would able to palpate the spinous process of the sacral and lumbar vertebra, ma'am. I couldn't feel any defect in the vertebrae, and I couldn't see any lateral vening scoliosis or kyphosis in the spine, ma'am.
Not having kyphosis, scoliosis, what is it implying from clinical examination? What vertebral abnormality causes kyphosis and scoliosis?
Kyphosis in the dorsal vertebra, ma'am, and scoliosis can be in the dorsal lumbar vertebra.
No, that's okay. What vertebral anomaly causes this? Why does it occur? What in the X-ray? Supposing you do X-ray, um, what you can expect? It's not common in, at least in the vestibular fistula, but since we are discussing it, what vertebral abnormality causes kyphosis or scoliosis in children with ARM?
I'm not sure, ma'am.
So it is hemivertebra. See, you just if you think of tuberculosis, the vertebral body has collapsed. So similarly here, hemivertebras may be there. in a very complex fashion, they can be there. More than one vertebra would be involved sometimes. So those changes will make the child have this. There may be absence. You can have all sorts of vertebral abnormalities. But for the sacrum itself, I think you have to be a little more specific how you're ruling out sacral abnormality.
By measuring the sacral index, ma'am.
No, that is from radiology. We haven't
Yes.
gone there yet, isn't it? It is just a clinical examination.
Any abnormalities on outside, ma'am, like skin changes, tuft of hair, or any palpable
No, see,
mass?
okay, but see, tuft of hair is for like spina bifida occult. It's also fine. You can have lesions inside the uh, spinal canal also. So you may have that. So
On crying, if any sacral defects are there, on crying there won't be any occurring at the anal site, ma'am.
okay, so the muscles themselves, it's almost it will be associated with a flat buttock and flat bottom itself, isn't it? Because if you have sacral agenesis, then there will be an associated deficiency in the muscle also. Your median raphe may not be well formed, and even the space between the like the bones, iliac bones, it may be less. That area may be less. So this is the other thing which you might find. You might find just a bulge in the perineum because of the weak muscles. You may see that also. So overall, the buttocks will not be well formed. You may have a dimple, sacral dimple may be there. So these things, I think you could have, in addition, you could have told us. Um, so also even sometimes they may have abnormalities in the leg, foot, club foot. There may be other associated problems, isn't it? Because
Yes.
nerves are affected. So what is your diagnosis right now?
My diagnosis is anorectal malformation with vestibular fistula with no associated anomalies.
You can't blanket say no anomalies. Some may be detected
No
later,
obvious,
but
yes.
at least externally, you've not been able to find anything. So how do you want to investigate this child?
I would like to investigate by 3 steps, ma'am. One is for the general fitness of the child. Other is to rule out this fistula and for the management of the fistula. And other third investigations are to rule out any associated malformations, ma'am, anomalies.
So just to go back to your examination, you have put a catheter into the urethra, and so did you put a catheter into vagina also?
Yes, ma'am.
Here there are two catheters from the picture.
Yes, ma'am.
So when you put catheters, in what order should you put it? Supposing you have only two catheters with you.
Urethral, vaginal, and anal fistulas open.
Okay, you have only two catheters. You put one into anus already.
Yes.
So after the remaining two, which one would you put first?
Vaginal, I'll put first.
Okay, and then you put
Urethral.
into urethra. Is that
Yes.
correct? What can happen if you do that?
Ascending infections can.
Yeah. So we should not do that. That's not correct. So urethra should be the cleanest, isn't it?
Yes, ma'am. Sorry. Sorry.
Just no, it's okay. Just ask because we keep seeing when people try to do that. So you should put in the urethra. So actually, I don't know if there was another picture, but there is no catheter in the vagina.
Yes, ma'am.
So can you actually miss a vaginal problem? How can you easily on clinical examination? What is a good technique to actually see the vaginal orifice? Or any of these here, two people, or I don't know if the same person, you are holding you're stretching the labia majora and you're trying to see the vestibule, isn't it?
Yes, ma'am.
Is there any other method which is very good to see these openings?
We can uphold the labia majora upwards, ma'am.
Yeah, you should hold both the labia majora with either hand, both hands, and pull it towards you, and then you will be able to see these openings quite well.
Yes.
Okay, so I'm interested to know about the vaginal opening actually. Did you put the catheter? You put, I think.
Yes. Yes, ma'am.
How much did you put, or were you happy after some time? You don't have to put it a lot, but you need to have some idea. But
it didn't get any resistance, ma'am, to rule out the.
Okay, so you are happy with that. You could actually put a catheter into it, because sometimes you may have a pit, you may think vagina is there, you may even write it in the notes, but actually when you operate, it may not be there.
Yes.
Any other vaginal abnormality may be seen in the clinical examination?
Any septated vaginas, ma'am?
So it may be absent, maybe just a dimple. Of course, there may be atresia, but you may are higher up, but you may not know initially, and you may have septa also. Fine. Okay. Can you go back to your next slide? Going for investigation. Yeah.
For general fitness of the child, we would do complete blood picture, random blood sugars, renal function test, serum electrolytes, blood urea, and serum creatinine, ma'am. And the radiological investigation concerned to the.
Sorry, no, just wait. Go back to that slide. So just say again, the blood investigations, what all are you doing?
Complete blood picture, random blood sugars, renal function test, serum electrolytes, blood urea levels, and serum creatinine levels.
So, and then you're doing X-ray, chest, abdomen, and pelvis. Okay, what is the rationale?
X-ray chest to look for any increase in the cardiothoracic ratio, ma'am, to rule out cardiac anomalies, and also to look for the cervical and dorsal-lumbar vertebrae. And X-ray abdomen is to look for the concerned bowel, ma'am, and X-ray pelvis.
No, what exactly? So anyway, I mean, chest X-ray routinely, probably it's not required. You could auscultate and see. Neonate, it's different. At 9 months in a child who was well all the time, echo is fine. Echo you should do. X-ray abdomen specifically, why are you doing?
To rule out any renal anomalies, ma'am, and to rule out
abdomen. No.
Yes,
X-ray abdomen, not ultrasound. Renal anomalies. What
X-ray
is the link
abdomen
with
to look for to know the to look for any dilated bowel loops, large bowel loop.
Yeah, even feculomas you could see.
Yes.
You will see fecal matter, isn't it?
Yes, ma'am.
Yeah, so she's a bit old for pouch colon. In a smaller child, maybe you would have done, especially if you were looking at cloaca, at least in North India, we would see. Yes. Pelvis, I'm assuming that you're doing for the sacrum.
Yes, ma'am.
Okay. And ultrasound abdomen. Ultrasound spine at 9 months.
No rationality, ma'am. I forgot to edit.
Yeah, probably, not really, not very much use.
Yes.
So is it essential to do a contrast study? Do you do it
Here not in all cases, ma'am. Here there is a dilatation of the bowel. So we want to rule out the ectatic bowel and any pouch colon association.
So these x-rays are done at this 9-month age?
Yes, ma'am.
Okay, just read it then. Can you read it?
First one is a plain x-ray of exposing chest and the abdomen. X-ray chest showing normal cardiac seal out with the normal cervical thoracic vertebrae, and X-ray abdomen is showing there is a dilatation of the large bowel with the
No, since you said cervical and dorsal spine is okay.
Yes.
What about sacrum?
Sacral, all ma'am, coming in abdomen I want to.
Okay, okay. Go ahead. And bowel gas pattern, what is your comment on that? No, you were trying to rule out something, isn't it? You said some ectasia of bowel.
Yes,
so in the plain X-ray, what are you saying?
dilated bowel loops, ma'am.
Okay.
Dilated distal bowel loop can be seen.
And what about the pelvic area? Do you
Pelvic
have
area
enough
there is
gas there?
no, ma'am. Rectal gas shadow is absent here, ma'am.
What do you think may be happening there?
Due to the fistula, there may be the collapse of the rectum, ma'am, which may leading to the dilatation of the distal colon. So there,
No. Say again, go slow. I want to just make sure you're understanding what you're saying. So you have a fistula. What happens to bowel proximal to it?
Proximal to it, there will be the dilatation, ma'am.
So here, what are you looking for?
Here, gas pattern is okay, ma'am. Progressively, there is an increasing gas pattern,
ma'am. But why is it not more dilated lower down?
Due to the collapse of rectum due to the fistula, ma'am, which may be the stenotic.
With that, how much length could be stenotic? Going by that X-ray.
We couldn't appreciate him until here.
Which is the sigmoid colon? Why should no? Yeah. No. Goes pushing too many things.
This one, ma'am. From here, ma'am.
No. Everything cannot be sigmoid colon.
No.
Just trace from rectum to sigmoid. From rectum to sigmoid. No. How does it go up? From rectum go up to sigmoid? Right. Okay. That's not normally how it goes, but maybe you have a contrast study, so I think you are a little biased because of that. Go read the contrast study, please.
Contrast study of the fistula showing in AP view, there is a normal caliber of the bowel with no feculomas seen.
No, you describe the fistula. Yeah.
And in the lateral view, there is the fistulous tract with mild dilatation proximal to the fistulous tract. But it is normal. It looks like normal caliber only, but it is a long fistulous tract.
No, but okay. But do you know where it's ending? Because they would have given you more views, isn't it?
Only AP and oblique view.
Yeah. So this is a very unusual kind of dye study, I would think.
Yes.
See, rectovestibular doesn't mean that the whole rectum becomes narrow. That is not what a rectovestibular fistula is.
Yes.
Can you describe a normal, like a anovestibular, rectovestibular fistula? What do you really understand by that word fistula? Like, what kind of anomaly is it? If you say low,
it's a
intermediate,
low anovestibular is a low anomaly, ma'am, and rectovestibular is an intermediate anomaly.
Yeah, so which means that the narrow segment is very short,
yes,
isn't it?
Yes.
How much length would it be normally, say anovestibular?
From
anovestibular, no, if you were to operate, what would be the length of that fistula?
It may be less than 2 centimeters, ma'am.
Yeah, hardly 1 centimeter.
Yes.
So same with rectovestibular, maybe 1 or 2 centimeters, not more. So do you think now with this dye study, can you call it as a rectovestibular fistula?
No, ma'am.
So what is it? What would you like to present it as? What is happening here?
The pouch and pouch perineum sacral distance is very less, ma'am, here. So it can.
Where is the from the dye in the AP view? I don't know. They seem to have started putting the dye quite high up, because you are seeing the pubic symphysis and ischial tuberosity. You're seeing everything, but there's no dye there.
Yes.
So they've injected the dye after going in quite a lot.
Actually, this is unusual contrast area, ma'am. They thought as a child is bigger, so they pushed most of the dye.
No, but they seem to have gone quite inside before they put the dye, isn't it?
They probed, yes, ma'am. Contrast area done by probing.
Done by?
Inserting a tip of the feeding tube, probe, inserting.
But how far in did they go? Because you may get a false report if they went in too, too high up and without giving you a proper information of what is happening lower down. Because if you see the AP view picture, it's already higher than the pubic symphysis. And you can see the, mucosal rugosity, some dye is there, some strands are coming down. But you don't see any dye below that. Of course, in the lateral view, you can see. But again, the question is, how much dye did they put? So if they put enough, then it's fine. You have to accept it, because your whole surgery will change now, what you're going to do. So, in this, so there is a question asking if you really need to do a contrast study. But, it depends on this. If you had this contrast enema, then you would think, okay, it's good we did it. But whether it was done correctly or not is the question. But even then, if AP view, we don't know, because they haven't gone right from the bottom. Your opening is in the vestibule. From vestibule to this area, it will be a good 4 centimeters or even more. On the lateral view, it's a little different, because you are seeing some dye which is just in front of the sacrum, isn't it?
Yes, ma'am.
So whether how much they injected, we don't know, but there is no air or anything else next to it. So with that picture, what is your diagnosis? Because I would have, they should take in different views, like oblique view also. Only then you would know exactly where this is ending, this long tract.
Yes.
So with this, what is your diagnosis?
As it is, as the fistula tract is passing upwards and posteriorly, ma'am, it is rectovestibular fistula.
Yeah, but the width of that appears very less, isn't it?
Yes, ma'am.
So would you like to add to that?
With no associated feculomas and no associated pouch column.
That's okay, but the picture looks like a stenosed rectum.
Yes,
very
ma'am.
much stenosed.
Narrowed. Yes.
That is not how it would be normally.
Yes.
Actually, what there's a question in the chat box also. So I would also think, what made us do the dye study?
As in
Is it because?
Yes, ma'am. In the plain X-ray, we couldn't find the rectal gas shadow. Along with there is a dilated bowel here.
No, dilated bowel will be there anyway. In all these children, dilated bowel will be there, but we would expect it to start lower down, which is not the case here. There's nothing. Sometimes there can be fecal matter, then also it can be opaque, like in this. So, did we give any rectal wash or anything before we did the dye study?
No, ma'am, not given. At the time of admission only, we did the rectal contrast study.
So I think AP view, not really. I don't know what is happening there. Dye seems to have been given much higher up, and there is some dilated, lower sigmoid rectum like thing. Little bit you can see, but you don't know what is happening elsewhere. But on the lateral view, you're only seeing a narrow tract, which is too long actually.
Long.
But supposing it was there, but the space between the sacrum and this narrow tract, like a rectal stenosis, the gap was more, then what would you suspect? Like you are seeing the same lateral picture, lateral view dye study,
Yes.
but there is, a black gray area between the sacrum and this. Or let us say part of the sacrum was not there. In the AP view, you found that some sacrum was not there, little bit, half the sacrum was not there. And you also find that there is some space, some more gray area between
Any,
the
any
sacrum and the dye which you're seeing.
presacral masses, ma'am.
What is it also called as?
Anterior meningocele or
What all can be the presacral masses?
it could be the anterior meningocele and the sacrococcygeal teratomas, ma'am.
Anything else? Could be anything. There are. What are the other presacral masses? Anyway, you could have duplication cysts also. You can have a lot of things which can happen there. So in the AP view also, you should look carefully for the sacrum, especially now with this X-ray. Although not very clearly seen, but I think all 5 sacral bones are there, isn't it?
Yes, ma'am.
Your AP view plain film, you can see that.
Yes.
So how many absence of how many sacral vertebra it
More than
becomes significant?
more than 3 vertebrae.
More than two itself will cause problems. And although done, so can you tell us the sacral, the ratio also in this particular child? Is it normal?
Yeah, I didn't measure it, ma'am, but
No,
I
but
know how to measure.
you know how
Yes,
to do it? Can you just
yes,
show with your marker?
yes, ma'am. Highest point of the iliac crest, it is taken as a point, and lowest point of the sacroiliac joint, it is taken as a B point, and the lowest point of the ischium is taken as sorry, ma'am. It lowest point of the sacral vertebrae is taken as a C point. It is divided by the BC by the AB ratio, ma'am. In the AP view, if it is less than 0. If it is 0.74, 0.77, and in lateral view, if it is 0.74, it is normal values, ma'am. If it is less than 0.4, there is a significant in the sacral index, ma'am.
Usually like S1, S2 are in your AB, and 3, 4, 5 are usually little below that. So when there is an agenesis, many times these go away, and then obviously there will be other problems with continence and everything else.
Yes.
So other investigate. This is your last slide, or you have some more slides?
Just for to roll out the spinal anomalies, and that's it.
So you already told me that.
Yes, ma'am.
All these are done now, is it? At 9 months of age.
Yes, ma'am. This ultrasound abdomen and pelvis are also normal, ma'am, and 2D echo is also normal.
Mm. Okay. So what do you want to do for this child?
I have planned for the staged procedure, ma'am, as due to there is a dilatation of the bowel and the long fistulous tract, and there is a extensive perineal excoriation on the examination. I would like to go for colostomy, and then after 3 months, then I would like to go for a definitive repair. And after the 3 months of the definitive repair, I would like to close the colostomy.
So would you like to do any other investigation, since we know that this is a very long, narrow rectum which is there, which is very abnormal. So although the space between the rectum and spine is apparently normal, But if you can always do a distal cologram once more. Make sure that what you are seeing is correct, because your approach would be quite different after that. So any other test, you just to make sure you're not missing something. Any other investigation you'd like to do? So I think definitely distal cologram you should do, just to make sure. You have to be really sure about it. Anything else? Let's say distal cologram also shows narrow.
I'm not sure.
I think you should rule out presacral mass. It doesn't appear on the on this X-ray which you have shown us right now. But it is worth checking.
Okay.
Okay, so now you want to do a what colostomy do you want to do? Sigmoid, divided sigmoid colostomy.
Yes, ma'am. Divided descending colostomy.
What do you mean by divided descending colostomy?
The stoma is performed at the junction of the descending and uppermost part of the sigmoid colon, ma'am.
Yeah. Why do we do that? I mean, what is the advantage of that?
There is usually there is no spillage of the fecal matter into the distal bowel and the cause of feculomas. And otherwise, there is adequate length to pull the bowel, ma'am, for subsequent procedures. And there is easy for further washes like rectal or fistulous washes preparation, ma'am.
So here you have to be especially careful because you have quite a long length which may have to be excised, isn't it?
Yes, ma'am.
Almost. Supposing this narrow segment was shorter, this narrow segment which we are seeing
Yes,
was shorter, then at what usually from a perineal approach, like a posterior sagittal approach, how far up can you actually reach and mobilize easily?
mobilization of the rectum, ma'am, till it falls at the proposed neoanal site, ma'am.
No, I'm asking you how far up from posterior sagittal incision, how easy is it to bring down normal bowel, depending on the length of this abnormal narrow segment, because here it appears to be very long.
Yes, ma'am.
It appears to be, I don't know, but it appears very long. Usually roughly like S3 vertebra, if you have the dilatation starts, then you may be able to do it from below itself. Here, even like S5, I'm not very sure where it is becoming, because there is a superimposition of some dilated sigmoid loop on this narrow area. So I don't know where it's ending. I'm assuming it's somewhere there. So in the second surgery, so basically that is the question. Now you've done a colostomy, which is correct. You've done
Yes,
that. So I'm very surprised that child managed with such a narrow bowel for 9 months. I'm really sure this mother must have been feeding only liquids to this child. But whatever said and done, yeah, that's true. So the diet is a factor here. Mother must have changed the diet to manage this long fistula. That's what I think. So we don't know. So now let us say you have done the colostomy, and always you should remember to clean the distal bowel as soon as you finish that. You must do that. Teach the parents also to do it. Even though it doesn't spill, as you said, it's a divided stoma. And definitely, I think if this long, narrow bowel is confirmed, you should preferably do an MRI or a CCT for the pelvis for this presacral mass, just to be sure. Unlikely, going by the film. And then you're going for your next procedure, isn't it? The definitive procedure.
Yes, ma'am.
So, when would you like to do that? Now that you're done the colostomy?
After 3 months of the first surgery, ma'am.
Okay, why do you want to wait for 3 months?
To improve the general condition of the baby, and also to manage the bowel, ma'am. The ectatic and the dilated bowel can be given washes, and it could be bring into the normal caliber, so that the post-operative event will be free, ma'am.
Okay. Okay, so after 3 months, you have admitted the child for let's say we have checked, confirmed everything. There's only this long segment. So how do you want to proceed for this child?
From the pre-operative period, shall I tell, ma'am?
Yeah.
Patient is kept on NPO for 24 hours prior to the surgery, ma'am. And
Why
then
24 hours? Because I heard this in the Vardia CME also. Why 24 hours NPO?
generally not a significant, ma'am.
You tell me what are the latest guidelines for NPO for children?
If for a primary definitive procedures, ma'am, it should be the total gut irrigation. It should start from the
Yeah, no, sorry. This now you've done we can
colostomy.
discuss that later. But for this child, you have done a divided colostomy, and you are happy with the length of normal or previously dilated bowel, which is normalized. You have enough length. Now, if you don't have enough length, then yes, to do a total bowel preparation, just in case you have insufficient bowel to bring down. But let's say you're confirmed with one more distal dye study, and you know that you have enough length of bowel which will come down. So you should wash that distal bowel definitely before surgery, which you can start at home and you can continue during the admission a day before. But I want to know why you want to keep a child NPO for 24 hours. Let's say the child is posted for 8 o'clock tomorrow. So do you want to start NPO from 8 today morning? So what are the latest guidelines about NPO for children?
If baby is on colostomy, ma'am, 5 to 6 hours before the surgery, we can start NPO, ma'am.
5 to 6 hours.
Yes, ma'am. As there is a protective colostomy.
No, colostomy is there. So this is like any other, say, a daycare surgery. So what is your protocol for stopping solids,
So,
liquids? That's what I want to know. Just
solids before 8 hours of the 8 hours of the surgery, ma'am. Liquids around 6 hours, and clear liquids around 4 hours, ma'am.
About breast milk?
It's 6 hours, ma'am.
No, it's supposed to be 4 hours. So semi-solid, liquid 6 hours, solid 8 hours. Some people even for solid say 6 hours nowadays. But breast milk is 4 hours, and then water or any other clear fluid is 2 hours.
2 hours.
So for this child, definitely 24 hours would be too much. She'll be crying and she doesn't get IV fluids. Or so if you are happy with the length of the distal bowel from the distal stoma, you can allow her feeds. There's nothing wrong. And you can always apply a colostomy bag so that it doesn't contaminate this area. But you can allow at least this new guidelines are what we said at the end about NPU. Okay, so that's just to understand. Okay, so now what surgery would you do for this child with this picture?
As this fistulous tract is long and narrow, ma'am, I would like to go for a posterior approach, posterior perineal approach. That is a posterior sagittal anorectoplasty, ma'am.
Do you think you can complete the procedure? This is what I asked you earlier. Do you think you can complete your procedure looking at this dye study by a posterior sagittal approach?
If we can't reach the exact site of the fistulous tract, ma'am, it can be done abdominal approach also.
No. So you must be more clear in your mind whether looking at the picture, will you be able to or not? You may have to do both.
Yes, ma'am.
Because you would probably want to excise this segment also. I'm only going by the dye study. I don't know how much dye they put into it And it's very unusual to have such a long tract. Very unusual. Because if it is a normal bowel, then you should not lose it. Because every bit of bowel is important for continence. So here, most likely, if we assume that the length, that's why I asked you about the length which you can mobilize by the posterior sagittal approach. So generally, what you can see here, that it will be very difficult for you to mobilize and bring down from below. It will be a little difficult. So you may need to do a abdominal and posterior sagittal approach. So if you were to do that, how would you proceed? Let's say you're first doing in a posterior. So how would you position the child?
It's a jackknife position, ma'am. After catheterizing the child, I would like to place the child in the prone position with the pelvis elevated by a bolster application and two bolster placed in the chest region and legs apart.
Which part of the body should be free for respiration for the anesthetist?
Abdominal, ma'am. Mid-abdominal part.
So you have covered the pressure areas and you've taken care of all that. You have applied the cautery plate. You position the child. Okay. And then?
Then I would like to start the incision from the mid-sacrum.
No, you have not catheterized the child.
Before positioning a patient only, I would like to catheterize.
You have already, you did?
Yeah.
I didn't hear that. Okay, fine. Okay.
Yes.
Go ahead with your surgery.
And I would like to mark the supposed neoanal site with a electric stimulator, muzzle stimulator by marking.
Supposing you don't have a electrical stimulator, can you still make out where the proposed anal site would be?
We can apply electrocautery, ma'am, just a second. We can see.
Okay. Even otherwise, can you make out?
But scratching over the perianal region.
That's when the child is awake.
Yes.
Anyway, see, usually it will be where you have that anal dimple. I think you showed us in the picture also. So, okay. So, what is the length of your incision?
It's from the mid-sacral region to the anterior edge of the neoanus, proposed neoanal site. Incision given in the midline and the skin subcutaneous tissue along with the parasagittal fibers are incised. Incision is deepened with
when
exposure.
You say parasagittal fibers, what happens? How do you see it? You cut the skin and the subcutaneous tissue.
Below to the skin only there will be arranged, ma'am.
How are they arranged? Parasagittal?
Along with this, parallel to the skin only, ma'am, they are arranged.
Then
sphincter muscle complex is incised. Then levator ani muscle is incised, and the dissection is started from the presacral region to expose the posterior wall of the rectum. White glistening structure it shows as rectum presents as a white glistening structure. After identifying the bowel, take two silk sutures apart at the 3 o'clock and 9 o'clock position. Then free the rectum laterally and mild somewhat anteriorly and incise the rectum vertically and identify the fistula. Sorry, ma'am.
So here this is a female patient where you have already opening is there.
Yes, sorry, ma'am. Mobilize the rectum posteriorly, laterally, and mobilization done anteriorly last with the mobilization of the fistula from the vaginal wall, which is long. It could be the long and long thin fistulas, common wall between the vagina and the rectum. Till the till we appreciate the till we can feel cervix external os, till that point we have to dissect, or till the bowel falls in the neoanal side, we can dissect the bowel.
In this particular child, what is the upper extent of your dissection?
Till the external os, cervical
No,
os.
that's okay. That is anteriorly.
Here till the dilated part.
No, there's a question in the chat box. I think we already discussed that repeating a distal cologram would be useful. So that's already asked. Yeah, sorry. You go ahead, please, Swapna.
Till the narrow, till completely narrowest part of the fistula should be come out, and a dilated proximal part visualization approached till the
so that's the tricky part here, because where is that dilated part starting, isn't it? Because then you have to bring that much bowel down. That's the question.
Yes.
Okay, so supposing you still find narrow bowel only as the maximum you could do, then you may have to turn the child. And before that, what can you do? Is there any way of doing a pull through without repeating? There are two ways of doing it. So supposing you're able to mobilize you can see the dilated bowel, which is a normal bowel, and you are able to dissect and bring it down because you have a good loop of sigmoid. So you may be able to do it. I can't say. Then it's fine. But if you can't and you have to go into the abdomen, let us say. So what would you do before going back to abdomen? Is anything needed? What will you do with this bowel which you have? Or do you want to just leave it as it is after dissection?
I'm not sure.
Just think, nothing, you can have different ways of doing it. So here, of course, it's in continuity. It's not that you didn't find anything. You have a long segment. So you could go to the abdomen. See, normally in a male patient, when you do a PSARP in rectovesicle, if you want to do PSARP as first approach, then you would open it and you may put a large bore tube there and then close the muscles around it. But here, so you could do that, but here you already have some bowel sitting there. So there are two ways of doing it. I mean, you could excise that or push it back up and then put a large bore tube and then bring it down in the supine position, lithotomy position. But generally doing a PSARP is superior because you can suture the normal bowel to the muscles much better. So it may be better to come back and continue the procedure from posterior sagittal approach only.
Yes.
Okay, so we'll assume that there is no presacral mass and you are able to bring the bowel down by whatever method. So how do you suture let us say you bring the bowel down and you're back to the posterior sagittal approach. How do you make sure that it's within the sphincter complex?
By identifying the anterior and posterior summits of the sphincter muscle complex, the dissected bowel should be placed within them.
No, before that, how do you construct the perineal body?
The anterior fibers of the sphincter muscle complex are sutured, so that adequate
vagina, if there's any vaginal tears, you will suture that.
We have to repair that.
So you will come from anterior, you will reconstruct the perineal body. So when you bring down bowel, what are the things which you keep in mind so that you do not have post-op problems?
It should have adequate blood supply and it should be adequate with no tension. It should be brought outside.
Yeah, but see, when you say no tension, it should not be very lax also. There should be a little bit of tension, little bit should be there. You should pull it in a way so that it's reasonably taut. It should not be too lax. Then also you can get prolapse. But as you said, blood supply is very important. And for that, cautery should be used very carefully, just low settings. When you dissect the rectum all round, even when you make the skin incision, it is better to use your knife rather than a cutting cautery to cut the skin subcutaneous. Only when required, you should use cautery. So to the extent possible, especially in the sphincter area where you have the, let's say, the superficial external sphincter complex, that area better to use knife as you cut along, because you can see it very nicely without any stimulation. You can see those fibers very nicely. So where do you place the main rectum? It should be within this. Yeah. So how do you identify it? How do you identify the sphincter?
These are perpendicular fibers passing to the levator ani and skin, parasagittal fiber.
Yeah, so they're perpendicular to parasagittal and levator, and they're a little whitish. You can actually make them out. They're a little different composition. So, and you have to suture this muscles with the rectum which you have pulled. That also will reduce the chances of prolapse.
Yes, to avoid retraction.
So, how do you take care of this child post-operatively? When would you allow orally for this child?
As it is under covering stoma, ma'am, after 6 hours surgery, we can start the orals, ma'am.
Yeah, you can start. Theoretically, yes. Maybe because you have gone into the abdomen, let us say, if you went, so you have made an incision and you have closed it. So you could wait for a day. Sometimes stoma doesn't work when you go into abdomen and close it. So, yeah.
After functioning of the stoma, I would like to start the orals, ma'am, if abdominal dissection is done.
And of course, in a female child, so what about the catheter? You catheterize this child?
Yes, ma'am. After
what do you do?
Here, after extensive perineal dissection is done, ma'am. Usually, so 3 days after surgery, we can remove to avoid the contamination.
Yeah, definitely. Because so because urine will come posteriorly into the wound, I'll keep it for 5 days. Definitely. You want that area dry. There's no point keeping it wet. But as you said, after a day or so, when stoma functions, you can allow orally. Now, after that, how do you take care of this child? Let's say 5-6 days, stoma is working, you remove catheter, and she can go home.
Yes, ma'am. I would advise the wound toileting and sitz bath for the attenders, ma'am. And then after discharge, I would ask them to come around 2 weeks after surgery, ma'am. And after examination of the perineum, if there is no any excoriation and the wound is healthy, I'll start the anal dilatations, ma'am.
Are you routinely doing anal dilatations?
Yes, ma'am. 2 weeks after surgery, we here do anal dilatations.
Is it required always?
According to new concepts, ma'am, there is no need for anal dilatation when it is adequately placed in the sphincter muscle complex and with no any wound infections or post-operative complications. There is no need for dilatations, ma'am. But as a protocol, we do.
She's 9 months old now. So what size dilator do you want to use? How do you start? Although I don't do dilatation, but only when necessary, I advise. But since you're using it, can you just tell how do you start? Like, what is your
the smallest number? The smallest number Hega dilator, which is snugly fitting into the opening, we have to introduce or insert into the opening, ma'am. And every 2 weeks we have to increase one size, ma'am, one number size. Then after complete dilatation, adequate dilatation, how we can achieve? We can see according to the age, ma'am.
For her age, what do you want? What size? I'm not a stickler for all this, but just asking.
At 8 to 12 months of the age, we use 14 number dilator.
So when would you close the colostomy?
After achieving adequate anal dilatation like 14 mm here, and within 3 months, 3 months post surgery, usual protocol here, ma'am, we will close the colostomy.
Yeah, there's no need to wait for ages. A stool itself will dilate the passage. Yeah. So, and as you said, if vascularity is good and you have done a good, so just although, how do you anastomose the rectum to the skin? What
We use absorbable sutures only, ma'am.
what is important when you do that? So the entire thickness of the rectal wall should be taken in your suture, not just mucosa. Whole thickness should be there. So that's why when you have brought down the bowel, any bowel which is not looking healthy should be excised, and it should bleed properly, and it should be a full thickness, whatever is there. If you do that, then there's hardly any reason why you should be dilating it. And also it should be a little taut. It should not be lax. If it's a little taut, then the skin also, they'll just come nicely and it will look like a normal anus almost. So this piece of bowel which you have excised, would you send it for histopathology?
Yes, ma'am. Any to rule out any associated HD also we can, as the narrow segment is.
Yeah, it's extremely rare, but so two things. One is presacral mass and the other is Hirschsprung. You have to, but as people have pointed out, and I also feel it's extremely unusual that this child presenting at 9 months without any complaints. So that's a little odd. So we don't know about that. So in general, for rectovestibular fistula, what is the prognosis for these children?
It's 100% functional outcome, ma'am. In recent
100%.
papers, they have
100%.
with the PSARP approach, they have given it as 100%.
No, I don't think that. If you ask, so what do you ask for these patients? What is going in favor for this child? What all are going in favor?
Here, no
What is
associated
needed? What
sacral,
is need? Huh? Yeah.
no associated sacral anomaly, ma'am. Here
Okay.
with a good perineum, ma'am, which says that my sphincter muscle complex is intact.
And bowel also
Sacral.
have good motility because there's no severe ectasia anyway. There is some dilatation, but not too much. So that is also in favor for this child.
Yes.
But some length of rectum has gone, but that's okay. It's not too much. And so what are the other abnormalities, other female anorectal malformations?
It could be perineal fistulas, ma'am, like a very rare, like H-type fistula. Perineal
What is the continence in perineal fistula?
It is normal only, ma'am, as it is some part of the
So
rectum
you are
is.
saying it is 100% for
Yes.
perineal fistula. And you said for rectovestibular also it's 100%. Is that possible?
In one recent paper, I have seen that, ma'am. Otherwise, I'll check once.
It's a bit unlikely, at least with this picture which we are seeing. It will not be 100%. So how are you going to assess continence in a child? She's 9 months, and then after 3 months, she'll be 1 year old when you close the colostomy. So at 1 year of age, now you close the colostomy and she's passing stool per rectum. Is it possible to tell how she'll be later? What are all the things which you may observe even in a small child?
Bowel habits, ma'am, associated with any fecal incontinence or any constipation.
No,
Usually,
what would make you think that Yeah, she's aware of passing stool. She's only 1 year old, but she may not talk. But would the mother know? What is the age, at least by Western concept, at what age
After
are
3 years.
these children? They say 3 years. So that's a long way away, no, isn't it? 2 years later. Before that, I'm asking, how would you assess, or what will you ask the mother? She's come to your clinic after surgery, after colostomy closure, 1 or 2 months later.
Any fecal soilings or perineal excoriation.
Okay. Anything else?
Constipation history.
Okay. Oh, I'm asking you more for so awareness of passing stool. Even a small child may show some, they may grimace, or they may do some maneuvers for mother to know that this child is going to pass stool. And also as you said, soiling and the frequency of stool. She may not be passing in the initial 2-3 months. She'll pass frequently because you've just opened up the perineum, all the muscles, and then closed again. But after a few months, say 3 months, 6 months, even these children would be passing stool only 2 or 3 times a day. And with time, even that will reduce. And as you said, excoriation.
Ma'am? Hello, ma'am?
There is some problem, Sweta.
Swapna.
No, Swapna.
Yes.
There is.
Okay, sir.
She. Hello.
Hello. Hello, sir.
Doctor. Yeah, madam has joined just now.
Okay.
You can talk to her, Swapna.
Hello, ma'am. Hello, ma'am.
Dr. Swapna,
Sir.
Use the word calibration rather than dilatation. What is the difference between calibration and dilatation?
Can you hear me now?
Yeah. We are hearing you, madam. Carry on.
Yeah.
There is some disturbance, madam.
Yeah, actually my laptop.
Your voice is not clear.
Is just using the phone. She can answer.
Ma'am, we can't hear you properly, ma'am.
Meanwhile, you tell what is calibration and what is dilatation. Difference.
Calibration with Hagar dilatation, snugly fitting Hagar dilator is inserted into the neo-anus. This is a calibration. If the size increases and if there is a need for increase in the diameter size of the dilator, then it is called as a dilatation.
So here, what do you want to do? Calibration or dilatation?
Here, initially, I would like to do calibrations.
Yeah, the calibration is enough. So the word calibration is correct rather than a dilator.
Yes.
Then how do you do it? How do you do and how long you want to do it? When you will start the dilatation and how long?
2 weeks after the surgery, I advise them for anal calibration, sir. After that, twice daily for 1 month, sir. In between, with the 2 weeks of duration, I would like to change the size of the anal dilator. Then after that, for 1 month, I would like to use it for once a day, sir. Then for after 1 month, it is used as a twice weekly. Then after twice a weekly, it is used for 3 months, sir. Around 5 to 6 months, I would like to do the anal dilatations.
So better to remember, start after 2 weeks and continue till 6 months.
Yes.
6 months.
Yes.
Suppose if the traditional dilators, metal dilators are not available, they are from a remote place, what do you do?
We will start with the insertion of the little finger, sir. As patient attended to start with little finger and progressively to the thumb, sir.
So, yes, mother's little finger she can use and then progressively increase the. Madam has asked you about the incontinence. How do you grade or how do you evaluate for an incontinence? So after surgery, suppose this child is 3 years. She has attained a toilet training, but still she is passing frequently without notice. How do you grade the incontinence?
According to the Kelly score and Wingspread score and Krickenberg's score, which are described in the books. Huh?
Okay. What are the differences? What is Kelly's score? It is a radiological score. Tell the PINA score, latest scoring. How many grades are they?
I'm not sure, sir.
There are 3 grades, 0, 1 and 2. 0 means always soiling.
Yes.
1 is occasional soiling with socially acceptable. That the child can move around, not much smell in the society. Grade 2 is a no soiling at all. So 0 is always soiling. 1 is minimal soiling and socially acceptable. Grade 2 is no soiling. Madam has joined, see?
Yes, sir.
Sorry, that internet was just it's very bad here. Surprisingly, it ran for 1 hour.
Okay, madam. Okay. You carry on, madam.
Yeah, for this child, we are expecting, but I don't know about the 100% part of it, but it's a better prognosis.
Yes.
Okay. Fine. So, supposing it is just like we can. I think for this particular child, probably nothing more to discuss. I think she's already told you about anal calibration, dilatation, and continence. And we think that there's no other urological abnormality, isn't it? But what are all the other problems? Can you get any other issues? How long will you follow up this?
Swapna?
Yes, yes. Till 1 year of age, around intervals of 3 months we will follow up, ma'am. From there till 3 years we will follow up 1 yearly, as there is no associated anomalies. Ask her to come every 2 years until pregnancy, till the child attains a puberty and at marriageable age, we can follow the patient.
So any specific things you will tell for pregnancy or anything for this child?
As she underwent a perineal surgery, ma'am, in the marital at the marital age and at the conception age, if she is conceived, we will advise a gynecologist as she underwent the perineal procedure. It should be done. It is advised to do the cesarean.
So supposing this child vagina was not there, you just had a pit and at surgery you found that there's no vagina. What are all the surgical inputs which you may have to do? What all can you do?
If it
Like
is a vagina,
in this patient, let us say on table you didn't find the vagina.
yes.
And
If it
there's
is
just
vagina,
a pit.
yes. If it is a vaginal atresia and not associated as a divagina or a didelphius, then we can go for.
No, go slow. Just use the word properly. What did you say? What do you understand by vaginal atresia?
It's a partial absent or a stenosis of the vagina, ma'am.
Okay. And then you use some other words after that.
In some patients, it is associated with double vagina, ma'am.
Okay. So you're basically telling the different vaginal anomalies.
Yes, ma'am.
Okay.
If it is isolated vaginal anomaly, ma'am, we can go for vaginal reconstruction with interposing bowels, ma'am. Or
She's
if it,
she is 9 months old.
not now, ma'am, at the age of puberty.
Can you do anything else during this surgery?
If she is associated with hydrocolpus, we can go for vaginostomy. In such 9 months of age, it is unlikely to present.
Okay. No, there's no hydrocolpus. I mean, I'm saying that the vagina is not there at the time of your dissection, or before that, you have realized that there's no vagina. Can you do anything else with that rectum which you were trying to dissect?
That rectum can be transposed as a vagina, ma'am.
It can be. We don't know if it's very stenotic, then it may not be of much use. It could be left behind for that. And then you could bring down the normal bowel. So what is the associated syndrome with the absence of vagina, some vaginal atresia related?
I'm not sure.
Is there any associated abnormalities in the, what is Mayer-Rokitansky Strasser syndrome? Have you read about
abnormalities of the Mullerian structures?
So what happens there usually?
There will be agenesis of the Mullerian structures, which may lead the structures forming from the Mullerian structures like fallopian tubes, uterus, and upper 1/3 of the vagina are absent.
There are all sorts of combinations. Sometimes you may have, those are the structures which form from the Mullerian ducts, but the ovaries are usually normal. So they may or may not get recognized very early, but then this child will then, they may have some rudimentary uterine horn, so they might present to you at the time of puberty also, but they will not have most of their, which part of the vagina?
Upper 1/3. Upper 1/3 of the vagina.
Anyway, you can read that because there's type 1 and type 2. and so they may be associated. So just as a general discussion, because for this particular case, probably I don't want to ask you anything else, but just as a general discussion for female ARM, you can tell us about little bit about H-type fistulas.
Management, ma'am.
How will they present? How will they present?
There will be a normal anal orifice with the extending in the fistula tract extending into the posterior fossette, ma'am.
Sometimes even we have seen with this anorectal, some stenosis also we have seen H-type fistula. So specifically because of, although in this child it's not there, but you must think about that. When you have an H-type fistula, you must make sure that the remaining rectum is normal. They may have a stenosis somewhere within the pelvis. There may be a stenosis. So they also may need a dye study, those patients also. So how would you operate? What are the different techniques for management of H-type fistulas?
For H-type fistula, I would likely go for anterior approach, ma'am, anterior sagittal approach. After lay opening the fistula tract, the probe or dilator is passed from the fistula tract to the anal region, ma'am. Then incision given over the tract and assessed, and if there is no fistulous communication, I'll leave it apart and dissect the anal orifice surroundingly.
Anyway, you have to make sure that you reconstruct perineal body if you have cut any of that. There are many ways of, some people just remove the fistula from the rectal side and, kind of intercept inside out, bring it to the vaginal side. But you must make sure that the two mucosas don't come in contact. So you have to reconstruct the muscle also of the rectum and close the vagina also, bring it down properly and close the muscle in between, because they do have a chance of recurrence. So any other condition where you may have a what looks like a normal anal canal?
Rectal atresions.
Okay. What are the types of rectal atresia? You know any classification for rectal atresia?
No, ma'am.
I think it's not very common, but probably in South India also you see quite a lot, I thought. You may have just a membranous septum, or you may have a short gap between the rectum and anal canal, or there may be a longer gap. There may be a rectal stenosis. That's why I was remembering this patient, although it's not in the normal location. And rarely you may have a rectal atresia with fistula. That is very rare. That was the 5 types of classification. I think Dr. Upadhyay had given that long back. So what is the prognosis in rectal atresia?
As sphincter muscle complexes are not intervened, ma'am, it will be a good prognosis.
Yeah, they have very good continence. So, like the 100% you said for rectovestibular, I wouldn't, of course you've read somewhere, so that's fine. But rectal atresia, definitely, if you have not injured anything, you can, because your sphincters are normal. Of course, they need a colostomy. You should not do without a colostomy, except maybe the membrane septum. Otherwise, you should have a covering colostomy. If you have that, then they'll have very good continence. And similarly, although not, you may have 2 openings, one of the, sometimes, so let's say you just have 2 openings within the vestibule. What are the possibilities? Because one is that the vagina is absent itself, like we discussed. And what is the other possibility?
Urogenital sinus, ma'am, or otherwise.
Okay. Yeah. So if it's apart from urogenital sinus, can there be any other condition?
With a single orifice in the vestibule.
Two openings. So you have urethra and vagina. One is the urogenital sinus and some vestibular or rectovestibular fistula. Supposing you have urethra and vagina, vaginal opening, you don't have an anal opening.
We could suspect rectovaginal fistula also.
Okay, it's also correct. But the child is not past meconium. Is there any other possibility?
ARM without the fistula communication.
What conditions?
Mostly Down syndromes are. Down syndrome is associated with this.
Of course, there was a paper long back from Perineal, and it's not that all of them have Downs. There are almost, they had 40-50% who didn't have Downs. So again, what is the prognosis there? In ARM without fistula, what is the prognosis?
If not associated with sacral anomalies, then good prognosis can be expected. As the blind pouch will be just 2 centimeters above to the perineum. It is.
So tell me, in which conditions in the female child would you do a cross-table prone lateral X-ray? Mostly we do for males, isn't it?
Yes, ma'am.
So in females, now that we have generally gone through a few conditions, where would it be useful?
This ARM without fistulous communication.
Yeah, definitely. Yeah. And maybe for cloaca also, it might be useful because you may see something there also. So, because then you can decide whether you will be able to do it in a. The question is always whether you can treat something by primary surgery or you need a colostomy. So in ARM without fistula, if you can see that it is reasonably low down, especially if a child has Downs, you don't unnecessarily want to do colostomy. So you can do male or female. You can do that. This X-ray would be good. So about urogenital sinus, how would you manage? What are the types of urogenital sinus? Do you see, apart from ARM or some types of cloaca, would you see urogenital sinus in any other condition?
I'm not sure.
When in CAH, you would see, isn't it? And the management is almost the same. So where can they join together, urogenital sinus? What levels? It's all right. Maybe you can read about it.
Yes, ma'am.
They can join at different levels.
Yes, ma'am.
Should we discuss anything more, sir? Dr. Are?
There are some comments and questions in the chat box, madam. Kindly go through it.
Okay, so yeah, I think we have already asked her about Mayor occupancy. I think this is more as an answer it has come. There's a question about posterior cloaca. So what is posterior cloaca, Swapna?
There is a urethral opening into the anterior rectal wall, ma'am. Urethral or vaginal open into the anterior rectal.
So I think ARM without fistula. Okay, I think that was the answer. For cloaca, AP abdomen is better. Okay, anyway, for all these patients, it's better to do AP view and even lateral. Sometimes there may be even air within the bladder. So lateral view also helps. So if you do a CTPL, you might see that also. So both should be done. In most of the more severe ARMs, you should do AP view and lateral view. You will get information from both these X-rays. I can't see any more questions.
So,
think-
anything? What about giving some laxatives or bowel wash and discharge the patient for some time, and on follow-up later, we can do a contrast study to confirm about the narrow fistulous tract.
Yes, sir.
So if we have a doubt about where they place the tip of the cannula, the catheter, then we should repeat the dye study. I think we discussed that earlier also. Because already she's 9 months old. These operations, it's better not to delay too much, because if you keep having bowel which is very dilated, then that itself will cause constipation later on. You want to decompress that bowel quickly, and the child should go to normal diet. But yes, it may be worth repeating the dye study. I think we discussed that earlier. And this also comment about Hirschsprungs, I think we mentioned that also.
Yeah,
And definitely this rectum should be sent for biopsy if we find a narrow segment, long narrow segment during surgery. So that's important.
clinical presentation does not fit with radiological findings in this case. That's what a comment from Dr. Suman.
Yeah, so I agree with that because we would have expected her to have more abdominal distension. That's why I said that the mother may be adjusting her diet. Otherwise, we cannot answer to this very long, narrow segment. She would have presented much earlier. There's no way this child would have stayed asymptomatic like this. So yes, repeat dye study after discussing with the radiologist how they did it, definitely worth doing, because it'll affect the surgery, the position of the child during surgery, whether you can do with just posterior sagittal or you need a abdominal approach.
What about the transanal repair of rectal atresia?
Yeah.
Maybe using the endoscopic light from the colostomy.
Yeah, so if we should know the gap between the two parts, like if you have type 2 and type 3, in type 3, it may be a little more. I mean, there are people who have pushed the upper end with a Haggard dilator and then from below also in a transanal approach. But I think if it's less than 2 centimeters, then yes. If it's more than 2 centimeters, it will be difficult. So you should do a dye study from above and below, measure the gap. And if it is less than 2 centimeter, or you find it's just a membranous septum, then yes. But sometimes rectal atresia can be associated with stenosis also. So proper dye study is important. And so only 1 or 2 conditions, types of rectal atresia, you could do it transanally.
Suppose if it is more than 2 centimeters, what is the approach you follow regularly, madam?
I have been doing only posterior sagittal approach.
Posterior sagittal,
Usually with that, I'm able to manage all these cases. Posterior sagittal approach, I think is fine. Only thing is you're opening the muscles and closing them again. But the visualization is very good. And what I find is the anus is actually very small. It is not like it is 2 centimeters long. At least I have not seen that. The ones I have seen is just about 1 centimeter. But you retain it, and with time it gives very good results. But I open and do it. Like I have been doing only posterior sagittal, because I have found sometimes there is some fibrous band between the upper and lower pouches, which I have to excise. It's completely disappeared. It's just a strand there.
Yeah.
So it is not that they're always sitting near each other. So I think a good dye study will help, but I prefer to do posterior sagittal approach only.
Is there any, what is the incidence of stenosis after the anastomosis?
Where in rectal atresia?
Yeah.
No, again, we are maximum you may have to do one dilatation. That's all. I have not found any long-term problem. But you have to make a wide anastomosis. But again, as I said, the anus is not very large. But we are able to, if you were able to suture, open it up properly, not just simple end to end. You have to cut it quite a bit, as much as feasible, and make a wide anastomosis. It should be okay. But yeah, they may need 1 or 2 dilatations.
There is one more comment. Role of CMV workup in H type of fistula.
Yeah, I mean, that may be, but it depends when the child is presenting. It may be you have to the history also, but they may not always present very early on. So you don't know. It may have occurred earlier. Some people say even some abscess may be there after which it has come. That may be previously there in the history. It may not be a very acute event. But I wouldn't do it routinely.
Yeah. I think that comes to the end of chat box. Comments and questions, madam.
Okay, there's one more question has come. In this case, is lap-assisted approach more useful? No, I think for this particular child, if that long, narrow rectum is there, you have to excise it. So for that, anyway, I think it will be better to do a posterior sagittal approach. By lap-assisted, you have to go right down, and this would be closely related to the vagina also, this rectum. So I don't think, because you're going to do a colostomy you cannot clean this bowel without a colostomy. Just with peg-lac or normal saline total gut irrigation, you cannot prepare this bowel. She's already 9 months old. And having a clean bowel is very important for this particular surgery. So I think colostomy is indicated. Once you have a colostomy, I'm not very having a lap assisted again. You would need 3 ports. So I don't think it's very useful. It's possible that you may be able to do it just with the posterior sagittal approach. If you cannot bring it down, then only you'll go into the abdomen. So at least for me, I don't think I'll do lap assisted to this child.
Yeah. What about sphincter saving ASARP for vestibular fistula? There's one more comment, question from chat box.
Okay. Yeah, I had also started doing it, and not for this child, obviously, but if it's very short vestibular fistula, we have done, and you are a little more concern is there whether you can stretch and tear the sphincter during the procedure. So you have to be very careful when you do it. But otherwise, it is possible. It is feasible, and then you preserve all the entire muscle complex actually. So it is feasible, but you have to be very careful when you do it, because just be trying to see everything properly, you might end up stretching the muscles and tearing them, which is the big advantage with PSARP. You're just cutting, but and then suturing, which is going against it, but you can reconstruct it very nicely. But if some muscles tear, you may not be able to reconstruct it that well. They just stretch and tear sometimes with SSARP. But yeah, we have also done a few cases.
But not possible when the fistula is long, particularly in this case.
Yes, yes, definitely. In this case, I don't think there's any indication, because
ASARP is not.
we feel that we may have to go into abdomen itself. So in that situation, 100% we should not think. I think they have asked just for a regular vestibular fistula, more like a ano-vestibular, just vestibular anus, but not for this long, thin rectum.
Yeah.
Obviously, you can't. Even ASARP, all these, even PSARP itself may not be sufficient.
I think
primary procedure doing in newborn, madam? Any experience? Primary procedure doing in the newborn period itself.
So I have not done for vestibular fistulas. I usually do it around 3 months of age. Down syndrome child, female also comes without fistula, like no anus, no fistula, and just the rectum has to be brought down, primary PSARP. Perineal fistulas, unless it's for a female, unless it's required, I'll wait a little bit. Male ARMs, we have done. Of course, last 1 year, nothing much really. But again, only for the intermediate ARM, and if the child's weight is good, say about 2.5 plus, and there's no severe abdominal distension, child is in good condition, then we have done for intermediate ARMs in males. Females, I wouldn't do unless it's a Down syndrome and CTPL shows that it is within 2 centimeters. But vestibular fistula and all, I wouldn't do it as a new unit. You can always wait.
Any other comment or queries?
Actually, we didn't discuss cloaca, I think. I don't know.
Yeah.
That was the part of the
We are planning to put cloaca as a separate discussion.
Okay, fine.
Case of cloaca as a separate discussion.
Because that it's a long discussion, so I don't know.
Yeah.
I think if a candidate, if she wants to ask anything, that will be fine.
Dr. Swapna?
Usually for the vestibular fistulas, ma'am, is anterior sagittal approach or posterior sagittal approach will be better, ma'am?
So it depends on what you're comfortable with and how you have been trained. Like I am more comfortable with PSARP, although recently we've been trying some SSARP, but that's what I have done. There are many people who have trained with ASARP. The thing is, in PSARP, you're cutting all the muscles, anterior, posterior, more or less, you're cutting everything. With ASARP, the posterior are intact, but you're cutting the perineal body and anterior muscles. So theoretically, it is cutting less muscles, but I feel that placement within the center of the sphincter complex, I find it very comfortable with PSARP. And I feel if you don't use too much of cautery, if you use it very carefully, then it doesn't really affect the continence. That is my experience. And I'm able to place it very nicely within that complex. I think that is also equally important with correct tension. All that is very easy for me to do. So dissection wise, it's almost the same. Separating from vagina, it's almost the same. It doesn't make a big difference. So it is how you're trained, what you're comfortable with. and not injuring anything and reconstructing everything properly. That is all there is to it. And you can easily extend it if it is you can adjust your incision depending on how much you have to dissect. So if it is a little higher up, you will make your extend your incision up to the coccyx. Otherwise, you can make a smaller incision.
Thank you, ma'am.
Thank you, madam. Thank you very much for your participation.
Thank you.
And it is a nice academic discussion. Thank you, madam. Good night.
Good night.